Let's begin this session of filariasis with a clinical case that illustrates this important parasitic disease. We have a 57-year-old male patient from Rompen in Pahang who presents with some concerning symptoms. His chief complaints include increasing weight gain and swelling of his lower legs, which has become so severe that he's having difficulty walking. When we take his history, we find that over the years, he's experienced recurrent episodes of fever, accompanied by swelling of his inguinal lymph nodes and itching. Interestingly, he also mentions having had numerous malaria attacks in the past. On physical examination, we observe that his inguinal lymph nodes are slightly enlarged. Most strikingly, both legs show marked deformity with significant thickening of the skin and greatly increased diameter. When we palpate the legs, they have a rubbery consistency. This clinical presentation is highly suggestive of chronic lymphatic filariasis, specifically elephantiasis. The patient's residence in Rompen, which is an endemic area, the chronic lymphedema, and the history of recurrent inflammation all point toward this diagnosis. Keep this case in mind as we explore the pathophysiology and clinical features of filariasis throughout this lecture. Their habitat includes blood vessels, lymphatic vessels, connective tissue, and serous cavities. This tissue distribution is crucial to understanding their pathology. Morphologically, adult filarial worms are slender and thread-like. The sexes are separate, and females are typically longer than males. These worms have an incomplete digestive system, which is characteristic of many parasitic helminths. The female worms are either viviparous or ovoviviparous, meaning they give birth to live larvae called microfilariae. This is important for diagnosis because we can detect these microfilariae in blood samples. The life cycle of filarial worms is complex and involves two hosts, humans and an insect vector, typically mosquitoes. In this cycle, humans serve as the definitive host because we harbor the adult parasites. The adult worms mate and produce microfilariae in our bodies, which are then picked up by mosquitoes during blood meals, completing the transmission cycle. The cycle begins when a mosquito bites an infected person and ingests microfilariae circulating in their blood. Inside the mosquito, these microfilariae develop through larval stages to become infective L3 larvae. When this infected mosquito bites another person, the L3 larvae are deposited onto the skin and enter through the bite wound. Once inside the human body, these larvae migrate to the lymphatic vessels and lymph nodes. In the lymphatics, the larvae mature into adult worms over several months. The adult worms can live for 5 to 8 years. The male and female worms mate, and the females begin producing thousands of microfilariae daily. These microfilariae enter the bloodstream and exhibit what we call periodicity. For Wuchereria bancrofti, there's typically nocturnal periodicity, meaning microfilariae appear in peripheral blood primarily at night, coinciding with the feeding time of the mosquito vector. This adaptation maximizes transmission efficiency. When mosquitoes bite and ingest these microfilariae, the cycle continues. The pathogenesis involves several sequential steps. It starts with a human reservoir, an infected person with microfilariae circulating in their blood. When a mosquito bites this infected individual, it ingests the microfilariae. Inside the mosquito, these develop into infective L3 larvae. The entry point is when these L3 larvae enter a new human host following a mosquito bite. The larvae then migrate to lymphatic vessels and lymph nodes, where they mature into adult worms. Here's where the damage begins. The adult filarial worms physically damage the lymphatic vessels. Additionally, they produce toxins that cause inflammation. Often there's secondary bacterial infection, particularly with Streptococcus pyogenes, which causes acute disease manifestations. This damage leads to lymphatic dilatation and slower lymph flow. Over time, with chronic disease, lymph accumulates in tissues. In the limbs, this causes lymphedema, the swelling we saw in our case patient. In the scrotal area, it can cause hydrocele, which is fluid accumulation around the testes. The acute episodes are characterized by inflammation and fever, while chronic disease results from progressive lymphatic damage and dysfunction. Filariasis presents with a range of clinical manifestations that we need to recognize. Let's examine the 3 main chronic complications shown here. First is lymphedema, visible in the image showing massively swollen legs. This occurs when lymphatic obstruction causes fluid accumulation in tissues. The affected limb becomes enlarged, with thickened skin that develops a characteristic texture. In severe cases, this progresses to elephantiasis, as we saw in our opening case. Second is hydrocele, shown in the middle image. This is an accumulation of fluid in the tunica vaginalis surrounding the testis. It's one of the most common manifestations of lymphatic filariasis in men, and can cause significant discomfort and disability. Third is chyluria, where lymphatic vessels rupture into the urinary tract, causing milky white urine due to the presence of lymphatic fluid containing fat. Patients often notice their urine looks like milk. Additionally, there's a condition called adenolymphangitis, or ADL, also known as acute dermatolymphangioadenitis, or DLA. This presents with acute inflammation of lymph nodes and vessels, fever, and pain. These acute attacks are often triggered by secondary bacterial infections and represent the body's inflammatory response to the worms and associated bacteria. This slide emphasizes a critical concept. Repeated attacks of acute adenolymphangitis are a major cause of worsening lymphedema. Acute adenolymphangitis, or ADL, presents with sudden onset of fever, pain, swelling, and redness along the lymphatic vessels and nodes. Patients often describe these as attacks that last several days. These episodes are frequently triggered by secondary bacterial infections, particularly Streptococcus pyogenes, entering through skin breaks. Why does repeated ADL worsen lymphedema? Each acute inflammatory episode causes further damage to already compromised lymphatic vessels. The inflammation leads to fibrosis and scarring of the lymphatic system. Over time, this progressive damage further impairs lymphatic drainage. The right side shows the progression of lymphedema through stages. It begins with reversible pitting edema, then progresses to non-pitting edema as fibrosis develops. Eventually, the skin becomes thickened and develops a characteristic texture, with deep folds and a warty appearance. In the final stages, we see elephantiasis with massive enlargement, skin thickening, and sometimes secondary changes like ulceration or fungal infections in the skin folds. This progression underscores the importance of preventing acute attacks through good hygiene, prompt treatment of skin infections, and proper foot care. Each attack prevented is damage avoided, potentially preventing progression to advanced disease. Let's review the diagnostic methods available, divided into direct and indirect techniques. Direct methods aim to visualize the parasites themselves. The primary method is peripheral thick blood smear examination. This is crucial. Blood must be collected according to local periodicity. For W. bancrofti with nocturnal periodicity, blood should be collected between 10 p.m. and 2 a.m., when microfilariae are most abundant in peripheral blood. The concentration of blood using filtration techniques increases sensitivity by concentrating microfilariae from larger blood volumes. Indirect methods detect evidence of infection without visualizing parasites. The rapid ICT card test detects circulating filarial antigen in blood and can be performed any time of day, making it very convenient. It's highly specific and remains positive even when microfilariae aren't circulating. Serological tests include ELISA, indirect hemagglutination test, and immunofluorescent tests. These detect antibodies against filarial antigens, indicating exposure to infection. Molecular techniques, particularly PCR, can detect filarial DNA with high sensitivity and specificity. This is especially useful in low-intensity infections. The choice of diagnostic method depends on resources, timing, and clinical context. In endemic areas, the ICT card test has become the preferred method due to its convenience and reliability. This slide shows real microscopic images of microfilariae in blood smears. The images display the characteristic appearance of microfilaria. These are the larval forms that circulate in blood. Notice their elongated, thread-like structure. Microfilariae have a sheath, a thin covering, and specific internal structures that help identify the species. When preparing a blood smear for filarial diagnosis, we use the thick blood smear technique. This method concentrates the blood cells and any microfilariae present, making them easier to detect. The blood is collected on a glass slide, spread to create a thick layer, allowed to dry, and then stained with Giemsa or field stain. Under microscopy, microfilariae appear as curved or bent structures among the blood cells. The morphological features we look for include the presence or absence of a sheath, the arrangement of nuclei in the tail region, and overall size. For Wuchereria bancrofti, the microfilariae are sheathed, and the nuclei don't extend to the tip of the tail. Identifying these specific features helps us distinguish W. bancrofti from other filarial species. Remember, the timing of blood collection is crucial. Collecting blood during the wrong time of day might result in false negative results even in infected individuals. WHO's elimination strategy rests on two main pillars: transmission control and morbidity management. Transmission control aims to interrupt the spread of disease. This has two components. First, mass drug administration, or MDA. This involves giving preventive treatment to entire at-risk populations, typically annually, regardless of infection status. The drugs used, usually a combination of albendazole with either diethylcarbamazine or ivermectin, kill microfilariae and prevent transmission to mosquitoes. When coverage is high and sustained, MDA can eliminate transmission within 5 to 6 years. Second, vector control targets mosquitoes that transmit the disease. This includes insecticide-treated bed nets, indoor residual spraying, environmental management to reduce mosquito breeding sites, and personal protection measures. Morbidity management addresses the suffering of those already affected. This includes hydrocelectomy, surgical correction of hydrocele to restore quality of life, foot hygiene programs teaching patients to prevent secondary infections that worsen lymphedema, treatment of acute attacks with antibiotics and anti-inflammatory drugs. Both pillars are essential. Transmission control prevents new cases, while morbidity management helps those already suffering. Together they form a comprehensive approach to eliminating lymphatic filariasis as a public health problem. This integrated strategy has been successful in many countries, bringing us closer to global elimination.